So we'll talk primarily today about some of the standards of care and then some of the newer data looking at the role of some of the more looking at anti-angiogenesis agents and also immunotherapy agents. This should work, right? The green arrow?
Green.
No? Is it not? There we go. Yeah. Okay. All right, so historically, mesothelioma is often thought of as a chemo-resistant disease. If you look back in the trials that were done back in the 80s and 90s, there really were very poor responses to systemic chemotherapy. Median survival on most treatment regimens was around 7 months. And just best supportive care alone for these patients was around 6 months. So it's hard to say there was a real benefit to chemotherapy back then. Single agent treatment with a platinum, cisplatin, or maybe even doxorubicin or gemcitabine was given back then, but without a defined standard of care. That all changed about 13 years ago with pemetrexed. So this was the pivotal trial that looked at pemetrexed in combination with cisplatin, and the Vogelzang study was published in 2003. It finally showed a survival benefit with the addition of pemetrexed to cisplatin. And the survival benefit was around 3 months overall survival. So that became the standard of care for patients with mesothelioma. Whoops, we missed a... So cisplatin, pemetrexed is and still remains the gold standard. You can use carboplatin instead of cisplatin for patients who have renal insufficiency or other contraindications to cisplatin, and it's probably similarly effective. There's non-randomized expanded access data showing similar response rates and survival. The standard is 4 to 6 cycles of this combination therapy. Now, as we've talked about earlier today, I think in looking at maintenance pemetrexed in lung cancer, for example, we don't know if that's the standard yet for mesothelioma. There's a large randomized phase 2 trial, CLGB study. It's ongoing, although accruing poorly. And so we may or may not ever know the answer to that question, whether or not maintenance chemotherapy should be given to these patients. So what about second-line treatment? Well, there's a variety of agents that have shown some activity. Single-agent gem, single-agent venetoclax. You can also combination data is there for gem and venetoclax. Other data for epirubicin, gemcitabine, I don't use that personally. But the response rates are generally low. You're seeing overall response rates in these second lines of 10 to 15%. Median survivals are in the order of 5 to 6 months on second line, and there really is no clear standard. So angiogenesis has been looked at as an option in treatment of mesothelioma. We know that inhibition of angiogenesis is important in multiple different cancers, and it's been looked at in single agent and combination therapies. There's a number of agents that will inhibit the VEGF signaling pathway, antibodies to VEGF, of course, bevacizumab. There are tyrosine kinase inhibitors, small molecule inhibitors of the receptor, the VEGF trap, and then antibodies to VEGF receptors such as ramucirumab. These are all commercially available and used in a variety of malignancies. So it was studied in mesothelioma several years ago in a combination with, at the time, cisplatin gemcitabine. So bevacizumab in a randomized trial showed, you can see on the graph here, no significant improvement in overall survival. Can't get to two lines that are more superimposed than that. What was interesting, though, was that the VEGF levels in these patients was prognostic. So patients with high VEGF levels seem to have a worsened overall survival. Patients with low VEGF levels seem to do better overall, regardless of the therapy. So it certainly is tantalizing that there may be some role for angiogenesis inhibition in these patients. And so the study that was done, so let me go back. There's a lot of other small molecule inhibitor studies that were done, a number of different agents, all of which showed very low response rates, single digit for the most parts, and no significant impact on what looked like progression-free survival or overall survival. Again, all very low in the order of 3 to 6 months. So no real winners were seen in those phase 2 trials. But more recently, the MAP study was done in France. This was a a trial, again, looking at the modern regimen of pemetrexed and cisplatin in combination with or without bevacizumab. Patients received 6 cycles of standard chemotherapy, again, randomized to get bevacizumab, and then continued on with bevacizumab maintenance for those patients. There was no crossover allowed in this study. A large study of 448 patients, so all done in France, so really a nice study that was done there. And here's what the data showed. It showed an improved progression-free survival. Patients who got bevacizumab had about a 2-month improvement in progression-free survival compared to just chemotherapy alone, and overall survival. So the patients had almost a 3-month overall survival benefit. This is really the first in the last, since 2003 with pemetrexed and the Vogelzang study, this was the first study to actually show some kind of survival benefit to the addition of another agent to that basic regimen. So based on that, adding bevacizumab to cisplatin and pemetrexed did improve progression-free and overall survival, but it was associated with some higher rates of toxicity, which I didn't show. But overall, there was no significant impact on quality of life scores. Again, like the prior study, VEGF levels were prognostic, but did not predict benefit of bevacizumab. So this has now become a new option for first-line treatment. It is now recognized in the update in the NCCN guidelines as a Category 2A recommendation. So for first-line treatment, patients can get cisplatin, pemetrexed, or cisplatin, pemetrexed, and bevacizumab. All right, so let's move on to maybe the more interesting side of this is looking at the immunotherapy in this disease. We all know that immunotherapy has become an important aspect in treatment of cancers. Cancers can avoid detection of the immune system, and immunotherapy enhances the ability for the body to detect and destroy malignant cells. Immunotherapy is like, I use this example with my patients, it's like the stepping on the gas or lifting your foot off the brake. You can provide stimulatory signals that will drive the immune system activation, or you can remove the inhibitory signals. And that's the majority of what is now commercially available is looking at inhibitory signal pathways, such as the immune checkpoint inhibition. So this is a figure we've all seen before, looking at T-cell activation, and the commercially available checkpoint inhibitors are looking at the two aspects of the interaction of T cells with dendritic cells and CTLA-4. CTLA-4 antibodies such as ipilimumab can inhibit that interaction and allow for improved priming of the T cell at the level of the dendritic cell, and then trafficking of the T cell into the tumor microenvironment. At the effector phase of the T cell interaction with the tumor cell, PD-1 expression on the T cell can be inhibited by antibodies such as nivolumab, pembrolizumab, and PD-1 expression on the surface of the tumor cell can also be inhibited by some of the PD-L1 antibodies that are now available, such as atezolizumab and avelumab as well. So there's, certainly the paradigm is there. These drugs are been shown to be active in a variety of malignancies, lung cancer, melanoma, you name it. We've seen responses across a broad collection of cancers. So this was looked at in mesothelioma as well, a large study looking at the CTLA-4 antibody tremelimumab. It's hard to say. So Tremi was evaluated in a randomized 2-to-1 randomization in patients who had prior treatment with chemotherapy. It was versus placebo. And again, a large study looking at overall survival as the primary endpoint. So this study accrued fairly quickly. Again, the previous data I can go back to and talk about. There was a phase 2 trial which showed evidence of a response in patients with previously treated mesothelioma. It was quite promising, and so that that data supported going further with a larger randomized trial. Unfortunately, the randomized trial was negative. So this is the data that was just presented at ASCO. Hetty Kindler presented the results of this study. And you can see the overall survival for patients tremelimumab versus placebo, no difference in overall survival, hazard ratio 0.92. So very disappointing. I think the preliminary data from the earlier study was promising, and this was a disappointing trial for all of us. In then looking at subgroups across that patient population, there didn't appear to be any subgroup that from a statistical perspective seemed to benefit from this drug. So this leads us to another study looking at PD-1 antibody. So pembrolizumab, as you know, is an antibody that inhibits PD-1. This was the basket trial called Keynote-028. It's a multi-cohort study of pembrolizumab in PD-L1 positive advanced solid tumors. So all the patients on this study had to be PD-L1 positive at 1% or higher. And this was the mesothelioma cohort that we did. So patients were treated with pembrolizumab at a dose of 10 milligrams per kilo every 2 weeks, which is higher than what the standard dosing is now. But nevertheless, patients that were then treated every 2 weeks, evaluated every 8 weeks for response. And they were allowed to continue on with treatment for those up to 24 months if they had either had clinical benefit or radiographic benefit. Primary endpoint of the study was overall response rate with secondary endpoints of progression-free and overall survival. So this is the anti-tumor activity that we saw in those first 25 patients. Preliminary data showed an overall response rate of 28%. If you look at the disease control rate, patients that had either partial response or stable disease, combining those two together, the disease control rate was 76%. So this, this was presented at the World Lung Conference last year, and we're actually going to be presenting the final data here in a few weeks. If you look at the waterfall plot on the left, even though 28% of patients had a response by RECIST criteria, about 60% had some decrease in the tumor volume. And on the swimmer's plot to the right, the duration of response was quite good. In fact, by the time of the data cutoff, we had not reached the median, and there were 4 patients who were still on study out to almost a year being on treatment. The progression-free survival at that time point was around, with the median was 5.8 months. The 6-month progression-free survival rate was around 50%. So this looks quite promising to us, to me, anyway. There's an ongoing trial at the University of Chicago. That's a larger study, larger phase 2 trial, enrolling. I think they're trying to enroll about 60 patients. Again, looking at pembrolizumab in patients as second-line therapy, and that's purely a second-line study, and it's for all comers, PD-L1 positive and PD-L1 negative patients as well. All right, so just at ASCO this year, Rafid Hassan presented data on avelumab, or avelumab, I guess that's how you say it, the Javelin study looking at this PD-L1 antibody this time in mesothelioma. His study was 53 patients, most of again which are epithelioid, which is typical, and there was no requirement for PD-L1 expression. The overall response rate and progression-free survival were assessed. The response rate was 9.4% in his data, but a fair number of patients, almost 50%, had some disease stability with a progression-free survival of 17 weeks, and it was well tolerated. So again, some tantalizing data as well in this patient population. So there's some other more novel approaches to immunotherapy that have been evaluated in mesothelioma. Listeria monocytogenes is a facultative anaerobe or aerobic anaerobic organism that probably everyone's aware of. Causes food poisoning, but it can be used as it's a very potent immunogenic stimulant, and it can be used as a vector for delivering a particular gene. Now, there's a Listeria vector that's been attenuated. It's a live attenuated, double deleted vector that has 2 genes missing, internalin B and actin A. This live vaccine can be administered, and it gets into the cell. So then in the little video we got showing there, you can see the red bacteria with an actin tail. They're swimming around the cell. Those are the wild type Listeria. The blue, you can see around there, kind of hovering around the nucleus, those are the live attenuated double deleted forms. So they're live bacteria, but they can't move around. They have no actin tail, and so they're non-virulent. But they do secrete an antigen. So CRS-207 is the Listeria vector that expresses mesothelin. And there's a trial that was done using this mesothelin vaccine. Patients were receiving priming vaccines of Listeria with mesothelin, expressing this mesothelin expressing vector CRS-207, and that was given in then subsequently given chemotherapy and then boost vaccinations. And what we saw in this study was that, in the waterfall plot on the left, about 85% of patients had some degree of tumor shrinkage. About 60% had a partial response. And that, at least numerically, looks promising. If you look back at the Vogelzang study with just chemotherapy alone, the response rates were a little bit less than 40%. So this does look, again, tantalizing data. And the median overall survival, at least this estimated from the original data we have so far, looks like there'd be about a 20-month overall survival for these patients. Again, that looks better than what we've seen historically. More recently, there was some data on a WT1 vaccine for mesothelioma. Now, this is a peptide vaccine. It stimulates CD4 positive T cell responses that can recognize WT1 positive tumor cells, and mesothelioma is almost universally WT1 positive. So preclinical models have shown that human T cells that are stimulated with these peptides can kill mesothelioma expressing cells that are expressing WT1. So the vaccine was 4 separate WT1 peptides that were given by subcutaneous injection. And there's a phase 2 trial that was done in patients who had therapy for their mesothelioma, and these patients all had to have some surgical intervention, so a pleurectomy, and multimodality therapy, including chemotherapy, and all of them had to be WT1 positive. So patients were randomized to receive the WT1 vaccine versus a sham vaccine. The primary endpoint of the study was progression-free survival, with an aim to end with a goal of increasing PFS at 1 year from 50 to 70%. This is data that was just presented recently here at ASCO, again showing with WT1 vaccine a numerically improved PFS and really quite significantly numerically improved median overall survival, even though it didn't reach statistical significance. I mean, the study really wasn't powered for overall survival, but this again is quite tantalizing as a possibility for a vaccine approach in patients who've had surgery. So a larger phase 3 trial will be underway shortly for the WT1 vaccine as well. So I just wanted to kind of summarize all these things really into one picture. If we look at the cancer immunity cycle, we can look at different points along that cycle in which we may be able to make a difference in how we can use the immune system to attack these cancer cells better. Chemotherapy, we know chemotherapy and radiation cause tumor destruction, antigen release. But we can also maybe enhance that by giving vaccines that will have allow more antigen stimulation, such as the WT1 vaccine or the CRS-207 vaccine. We can use checkpoint inhibitors like anti-CTLA-4 antibodies or PD-L1 antibodies to enhance T cell function, and maybe using anti-angiogenesis factors to enhance T cell trafficking or make the tumor more permeable to treatments, to chemotherapy, et cetera. So we have to think about, when we think about combination therapies, which is really where this is going, looking at different points along the cancer immunity cycle, and use rational combinations to improve outcomes in these patients. I think that's my last slide. I think that's it.